So now we will be discussing about the horizontal jaw relation. In the jaw relations, there are three types, as we have discussed about the vertical and orientation jaw relation. So this is the horizontal jaw relation. That is a relationship of the mandible to the maxilla in horizontal plane or in anterior-posterior direction. And it can be of two types, centric and eccentric. Centric and eccentric. And we will discuss about the theories of centric relation, methods of recording centric relation, which are functional, physiological, and graphic methods. And then the eccentric relation are of two types, protrusive and lateral. So horizontal jaw relation is in this. There are two types of horizontal jaw relation, centric and eccentric. What is jaw relation? Is partial relationship of the mandible to the maxilla, and horizontal jaw relation is the relationship of the mandible to the maxilla in a horizontal plane, or it is a relationship of the mandible to the maxilla in an anterior posterior direction. What are the types? Types are the centric and eccentric. Eccentric are protrusive and lateral are left lateral, right lateral. What is centric relation? According to activity 7, the definition of centric relation is the most retruded relationship of the mandible to the maxilla. Most important is the most retruded position, and when the condyles are in the most posterior unrestrained position in the glenoid fossa, from which all lateral movements can be made at any given degree of jaw separation. So that was the centric relation position. That was the most retruded relation of the mandible to the maxilla. So in this, the condyles are in the unrestrained position in the glenoid fossa. The revised definition according to GPT-8 is a maxillomandibular relationship in the which the condyles articulate with the thinnest avascular portion of the respective disc with the complex and anterior superior position against the slopes of articular eminence. And this position is independent of tooth contact. It is clinically discernible when mandible is directed superior anteriorly and is restricted to purely rotary movement about the transverse horizontal axis. So we'll discuss in splits like what is the centric relation definition is maxillomandibular relationship. So centric relation is maxilla and mandibular relationship. So what it is, the relationship of condyle with the glenoid fossa. That means it is a bone-to-bone relationship, and there is no relationship of the tooth contact. It is independent of tooth contact. So we doesn't need teeth to determine the centric relation position because it is a bone-to-bone relationship. And this condyles will articulate with the thinnest avascular portion of the respective disc with a complex and anterior superior position. So condyle movement will be the anteriorly and superiorly and anteriorly move position against the slope of glenoid fossa. This is glenoid fossa, and this is the movement of the condyle, position of the condyle. And this position is independent of tooth contact. It is a bone-to-bone relationship, and it is clinically discernible when the mandible is directed superiorly and anteriorly. When we guide the mandible superiorly and anteriorly, and it is in the in this the condyle will exhibit only purely rotary movement, and rotary movement occurs around the hinge axis. So terminal hinge axis. So what are the mandibular movements? Mandibular movements are like they are the rotary and the translatory. In rotary movement, only the pure rotation on the condyle occurs, and in translation, and there is a downward and forward movement of the condyle also. And so the hinge axis also changed along with the translatory movement. So in this, the hinge axis is the axis along which the condyle rotates. Is the axis, and that axis is called hinge axis. So a mandible will exhibit only pure rotary movement about the transverse horizontal axis. In this diagram, we can see this is condyle. These are the retrodiscal tissues. This is the articular disc, and this bony part is the glenoid fossa. So this is the anterior and superior position of the condyle against the slopes of the glenoid fossa. These are the slopes of the glenoid fossa. So this is the position of the condyle in the centric relation position. What is the purpose of recording the centric relation position? Main purpose is as it is a constant position, so it acts as a reference position to record all the mandibular movements. So it is a bone-to-bone relationship, and it is constant. And main purpose is like in the edentulous patients, we know that we do not have any proprioceptive center which can act as a guide to all of our mandibular movements. But in the edentulous patients, teeth The periodontal ligament in the teeth act as a proprioceptor center to guide all the movements. And so this proprioceptor impulses in the edentulous patient are sent by this is generated by the centric relation position, which acts as a guide, and it is a constant position. So it will act as a proprioceptor center in the edentulous patient. So it is very important to record the central relation position, and then we can fabricate the dentures in the centric occlusion position, which is in coinciding with the centric relation position. So it is not necessary that centric relation should coincide with the centric occlusion, but in the complete edentulous patients, we need this relationship so that we take it as a reference relation. Centric relation acts as a reference relation. Why we are taking it as a reference relation? Because it is acts as a reliable guide, and because it is repeatable, it is recordable, it is a single relationship. It will be similar throughout your life. It is a definite learned position. It will not change. So this is the constant position, which is constant throughout our life. So this is very important to keep in mind while recording the centric relation position, and these are the significances. So what is it is related to terminal hinge axis. In centric relation, condyles exhibit purely rotary movement without any translation. Functional movements like moving and falling can be carried out in this position because it is the most unstrained position, and the final act of the masticatory stroke ends in the centric relation position. Functional movements like the chewing and swallowing, because it's a very comfortable position for the patient, so he can carry out all the chewing and the swallowing movements, and also it acts as a reference relation, and it is better than the vertical relation. It is more definite because vertical relation dependent on the tooth contact. When the tooth to tooth come in contact, then at that position we determine the vertical dimension of occlusion. But this is relationship is independent tooth contact, so it is more definite, and all the movements are carried out in this position because it is the most comfortable position for the patient. What are the criteria for mandible to be centric? Disc should be properly aligned on both condyles. Condyle disc assembly at the highest point against the posterior slope of eminentia, and medial pole of condyle disc assembly should be braced by bone. What are the theories of centric relation? Theories which we'll be discussing regarding centric relation are the muscle theory, ligament theory, osteofiber theory, meniscus theory. Why these theories? These theories will help us to see this forms anatomy like muscles, ligament, osteofibers, meniscus. They forms anatomy of temporomandibular joint. So these theories will help us to see like what is keeping the mandible in the condyle in the same position. It is in this constant position throughout the life. So what is the which is not creating any movement of the condyle, and why this fixed position is there? What are the anatomical factors which are affecting this position? Muscle theory in this, whenever the movement, this is the lateral pterygoid muscle. We know that temporomandibular joint is influenced by this lateral pterygoid muscle. This is the superior head and the inferior head. And when the movement occurs, defense reflex occurs, external pterygoid muscle, like the when the rotary movement of the condyle occurs in this, and the condyle is against the superior anterior superior position against the slopes of the articular eminence, and then these muscles they contract and they halt the jaw in this position. Ligament theory, we know that there are four kinds of ligaments: sphenomandibular, spinomandibular, stylomandibular, lateral ligament, which binds the temporomandibular joint, and these ligament the binds elements of articulation. And but in the lateral radiographic view, we can see the suspended or floating condyle. So this anatomical arrangement is not well suited to halt the retrusive movement. So this theory was not accepted. Next theory was the osteofiber theory. This was given by Mayer. In this, they said there is a fibrous top which acts as a there is a fibrous capsule here, and this fibrous top acts as a buffer. And this retrodiscal tissues they act as a they prevent the retrusive act as a retrusive terminal stop, and they prevent the more retrusion of the mandible. It guides the posterior most and the most retruded position of the mandible of the condyle and the gleaner fossa. So this retrodiscal tissues, they act as a retrusive terminal stop. This theory was accepted, and this meniscus theory In that, the fibrous capsule was acting as a buffer. In this also, the posterior superior surface unfolds along the roof of the glenoid fossa. So the disc in this, the articular disc also, and with the meniscal fibrous tissue stop the retrusive mandibular movements. This is the lateral pterygoid muscle. This is the retrodiscal pad. So in this, they are saying that the posterior surface of the disc and the along with the retromeniscal fibrous tissues, these tissues, they prevent the more retrusive position of the mandible, position of the condyle and the glenoid fossa, and they stop the retrusive condylar movements. So this guides the posterior most position of the condyle in the glenoid fossa. What are the factors which are influencing the centric relation record? Resiliency of the supporting tissues, like if the supporting tissues are flabby ridges in such cases, it affects the stability of the record bases, hence affecting the centric relation records. Fit of the denture bases, if the denture is not fitted properly, the impressions are not properly made, then automatically the centric relation records will be affected. Residual alveolar arch in CBD resolved ridges, there is improper retention of the dentures or the record bases, then it will affect the centric relation records, more saliva, tongue, health and cooperation of the patient. More cooperative the patient is, then he can easily help us in guiding the mandible to the centric relation position. Posture of the patient should be seated upright. Temporomandibular joint and associated neuromuscular mechanisms. There should not be any disturbances or any disharmonies in the temporomandibular joint with the musculature involved. And the skill of the dentist, like in the active method, when the dentist is guiding the mandible to the position, to the centric relation position, if the dentist is unable to do that properly, then we is unable to record centric relation records properly, then also it will hamper the records and the proper position. And also the pressure, if we are applying too much of pressure, heavy pressure in recording the centric relation position, then that will also affect the, and we cannot determine the relation at predetermined vertical dimension, so it will change the vertical dimension also, and hence pressure is also affecting the centric relation records. And the technique used and the recording devices used. So the recording devices, like the check record materials used, some material have better dimensional accuracy, some materials does not have the same, so it will affect the accuracy of the centric relation records. What are the difficulties which can be faced in obtaining mandibular retrusion? It could be biological difficulties, like the temporomandibular joint disturbances, mechanical difficulties, like the different kind of methods used. If we are using more pressure with any of the method, if we are using any improper material in registration of the record, so that can affect the record obtained. And the biological methods, the psychological methods, like the patient is uncooperative, he is not ready to move to that position, he is going to the habitual centric relation position only, because in the long period of edentulous, patient attains an habitual centric relation position and they find it more comfortable. So it is difficult if in the patient is not cooperative, and it's difficult for a dentist to guide him into the centric relation position, then that can create difficulties in obtaining mandibular retrusion. So what are the methods which of assisting the patient to retrude the mandible? These methods could be active or passive. Passive methods done on part of the patient, and active methods done by the dentist. So passive methods, like the ask the patient, we will instruct the patient and he will perform the movements. So we'll ask the patient to relax his jaw, pull it back and close slowly on the posterior teeth. This is one of the method. Another method could be the push the upper jaw out and close on the back teeth. So you will say that how the push the upper jaw out, maxilla is immovable, only the mandible is movable. So if we'll ask the patient, instruct the patient to push the upper jaw out, he automatically he automatically pull the lower jaw down backwards and close on the back teeth. So this can also be one of the method, passive method. And ask the patient, like a patient is sitting so in the waiting area or like just sitting on the chair, so we'll ask the patient to protrude and retrude the mandible repeatedly. And as we'll ask him to do it repeatedly, so then he will be so tired that he'll try to go into the comfortable position. As soon as we'll ask him to stop, he'll go into his comfortable position, and that comfortable unstrained position will be the centric relation position. So this is also one of the method to guide the patient, to assist the patient to retute the mandible. Another method is roll the tongue backwards towards the posterior border of the upper denture and close the rims until they meet. By rolling the tongue backwards, we will towards the posterior border of the upper denture and close the rims. Then there will be the centric relation position, because the tongue by the movement of the tongue, the mandibles are condyle are going in the centric relation position. This in this article they have given this as a guide to pull the tongue backwards, so that the tongue is in that position only when we are guiding the mandible into the, and it guides the mandible, the tongue position guides mandible into the centric relation. Another is the boost, stretch, relax exercises, in which the patient are asked to move up. Patient is asked for the movements like the protrusive and retrusive movements, and then the tilting the head backwards and ask the patient to swallow and close. There also another method for retruting the mandible. In this method, you can see in this diagram, this is the bilateral manual manipulation method. In this, patient is the dentist is keeping the patient has head is tilted backwards, and the dentist is guiding the mandible from behind, so that the thumb region is on the symphysis part, which is guiding the mandible, and all other fingers are on the lower border of the mandible. So this thumb region will guide the mandible into the centric relation position. This is the very important and the mostly followed technique. It's a Dawson bilateral manipulation method. And another method is to ask the patient to swallow and close. We know that functional movements like swallowing and chewing, they are performed at the centric relation position. So, by swallowing movement, we can attain the centric relation position. So, what are the requirements recording the centric relation position? The primary requirements are accuracy, equalize vertical pressure, and the recording medium should be of uniform consistency, and they retain the record and distorted condition. What we require is the pressure applied should be equal, and the recording medium should be of proper consistency, uniform consistency, and the records which are obtained, we need to maintain the records in the same condition. If the distortion will occur, then they will hamper the centric relation recorded. With minimum, we can use the pressure while recording. Pressure used while recording the centric relation can be the minimum closing pressure, heavy closing pressure. Now we will discuss the methods for recording the centric relation position. So the methods can be the tactile intraocclusal check record methods. These is the physiological methods. Functional methods, they are the Chewin methods, in which the patient is asked to perform the functional movements. These are the Mayers, Patterson, Hiedelhaus method. The graphic methods, intraoral, extraoral tracing, terminal hinge axis method. Other methods are the pantography and the deglutition. So tactile and intraocclusal check record methods. This method was given by Philip Pau, and it's also called as biscuit bite. This depends on the patient proprioception and the tactile sense to record the intraocclusal check records. What is the indication of this method? Abnormally related jaws, excessively displaceable supporting tissues, large tongue, abnormal mandibular movements, peripheral occlusion in the existing dentures. So we can help, this method can be used between the upper and lower rims. It can be used between the upper and lower artificial or natural teeth, and it also can be used between a central bearing plate and a pin and the Goetheka's tracings. Like material which are used for the bite registration materials are the waxes, quick setting plaster. Waxes like the alu wax can be used, quick setting plaster, impression compound, zinc oxide eugenol, bite registration paste, and zinc oxide bite registration silicone. These are the materials which can be used as a recording materials for the check, for making the intraocclusal check records. What is the technique for intraocular check record? It's a physiological technique. In this, first we will determine the tentative jaw relation using the occlusal rims. And after determining the tentative jaw relation and mounting the cast in the same relationship with the teeth arranged, we will make the intraocclusal check records. during Trine procedure. So intraocclusal check records are made like the during the Trine procedure. We'll put the material in the place between the teeth, and we'll ask the patient to close into the centricillation position, guide the mandible into the centricillation position, and then we will verify that in the articulator whether it is the check records which are obtained in the after with the teeth, and we will put the cast back into the mounted cast, put the rims back into the mounted cast, and then we will check for the records obtained with the teeth in place, and then we can verify the centricillation. Next is the pressure-less method, which is a neck and notch method. In this, we will prepare the neck and notches on the maxillary occlusal rim, and the trough is prepared on the mandibular occlusal rim, and the position of the trough should coincide with the position of the neck and the notch. Neck and notches, they are the V-shaped valley-like depressions, and neck is prepared like halfway along the surface of the rim, and the notches are prepared along the whole surface of the traversing the whole path of the rim. And this neck and notches, they are V-shaped. So, and coinciding in the same position, we will make the trough on the mandibular occlusal rim. And then we will put the bite registration material. This is the softened alu wax, which is placed on the trough, and we'll ask the patient to guide the mandible into centricillation position, or ask the patient to pull the mandible backwards, so that we can achieve the records. And these records, see this, the indentations are obtained of the neck and notches on this record. So this can help us to record the centricillation position. And will mount the cast in the same relationship obtained with the help of the neck and notch method. Stapler pin method. In this method, we can lock the centricillation position with the help of the stapler pins. Like in this, we'll retrude the mandible into place into the centricillation position, and then we will scribe some lines onto the maxillary and mandibular occlusal rim, and these lines should coincide with each other. And then we will verify these lines, if their lines are coinciding with each other again and again whenever we are guiding the mandible to the centricillation position. And if they're coinciding again and again, that means this is our centricillation position, and we will lock this position with the help of stapler pin. Next method are the functional twin methods. They are the Mayer's method, Peterson Needlehouse method, and like the Mayer's method. In this method, also one of the method in this, sorry, I forgot to discuss about that. In the this neck and notch was a pressureless method. Another method is the pressure method. In that, we will place the softened occlusal rim onto the mandibular record base. We'll put the rim onto the record base, and then ask the patient, and we'll guide the mandible into centricillation position, and we'll put some pressure on by guiding, so that the mandibular rim is mandibular rim, softened rim is in the proper position, is guided into the position. So, but the problem with this method is the pressure which we are exerting, that can create discrepancies in the records, in the relations, and with the pressure, we cannot determine the maintain the vertical predetermined vertical dimension, because with the pressure, patient can exert more pressure, and this can affect the centricillation record also, because we cannot maintain the predetermined vertical dimension. Next method is the Mayer's functional method. Mayer's method is in this is also kind of the method which we have discussed, like the pressure method. In this, we are using the softened wax, but with the softened wax, we are not just guiding the mandible to the centricillation position. We are asking the patient to perform the mandibular movements, and that will create a generated path. Next method is the Patterson method. In this Patterson method, we'll make the wax occlusal rims, and then we'll make a trough on the mandibular occlusal rim. This is the long trough which is made, and we load this trough with a mixture of carborundum and plaster, half carborundum and half plaster. And then we will ask the patient to perform mandibular movement. This is the loaded trough, and then ask the patient to perform the mandibular movements. And patient is asked to perform the movements till the predetermined vertical dimension is obtained, and then we will see the compensating curve is generated. So this was the Patterson method. Next is the Needlehouse method. In this method, occlusal rims are made of the impression compounds. And 4 metal beads or styli are attached on the premolar and the molar regions on the maxillary occlusal rim. So now this is also a functional method. So patient is instructed to perform mandibular movements. What kind of movements? Like the first will guide the mandible to centriculation. Then from the centriculation to protrusive movements, right lateral, left lateral. Then the diamond shaped tracing can be seen on the mandibular rim, and this dimension tracing, this point of the diamond shape tracing depicts a centric relation position. Those were the Needlehouse method, Peterson method, Mayer's method, which are included in the category of functional methods because they are performed with the functional movements. They are recorded using the functional movements. Next method is the graphic methods. In the graphic method, the types of tracers we are using, and this is also called the Gothe-Kash tracing, arrow point tracing. And in this, we are making the tracing in one plane, and apex is the most retruded position of the condyle in the Gleason fossa. That is, the apex, sharp apex depicts a centric relation position. What is the advantage of the graphic method? It helps us to verify the centric relation, and it helps us to obtain the protrusive and lateral records. What are the types of the tracers? Intraoral tracer and extraoral tracer. This is in the diagram, we can see the intraoral tracer with the tracing assembly in place. And this tracing assembly is also called central bearing device because it centers the forces all along the into the center. All the forces acting on the supporting structures are centered in one point. So that is why this assembly is also called central bearing device. So this is the central bearing plate, and this is central bearing plate with the pointer attached. And this is the intraoral tracing assembly. So patient has to perform the mandibular movements, and with these movements, the stylus or pin will make the markings or arrow point tracing on the plate. See this, you can see the intraoral tracing done with the intraoral central bearing assembly in place, and the patients asked to perform movements, and the tracing is obtained, arrow point tracing, and then check records. The records are made in place. Next is the extraoral in the graphic method. Next type of tracing is the extraoral tracing. It is also similar, but the difference is that and the difference advantage is that we can visualize the tracing happening when the patient is performing movement because the tracers are attached extraorally. And when the arrow point is made on the plate, which is visible extraorally. So patient can guide the dentist can guide the movements accordingly because he can visualize the markings being made, and he can see whether the right movements are being patient is making right movements or not. So this is also known as height tracing device because it was given by scientist Height. And this, but the disadvantage of the extraoral tracing assembly is that it is since we are the styli and the pointer is attached and the plate is attached outside the patient mouth, so they're away from the TMJ. So that can affect the centric relation recording because more the closer to the TMJ, more precise the recording will be. So intraoral tracers has this advantage over the extraoral tracing. See this in this diagram, you can see that extraoral tracing obtained. This is the plate on which the tracing is obtained. So we will color it with the white plaster or with some blue ink or with the black charcoal so that the lines are properly visible on the plate and the arrow point tracing is correctly visible. This is the Gothe-Kash tracers in place and on the maxillary mandibular card. What are the types of arrow point tracing obtained? It can be typical. This is with the sharp apex, and in this sharp apex, the centric relation position. This is the line of protrusive recording. This is the left lateral, right lateral recording, and it can be flat also. It can be asymmetric. It's the absent apex, miniature tracing, double arrow point tracing, dorsally extended arrow point tracing, interrupted form, atypical form. All these variations can happen when there is not proper tracing. Proper tracing is only the typical one, typical arrow point tracing. When there is not proper recording on the centric relation position, then these tracings can be obtained. It could be due to all the difficulties which we have already discussed, biological, mechanical, or psychological. So proper tracing is not obtained. Another method is a terminal hinge axis method. It is an imaginary line around which the mandible may rotate without translatory movement. Other methods are the deglutition method, pantographic method, physiological method, swallow and hold. This physiological centric relation swallow and hold method was given by Shanahan, in which the patient has to swallow and then hold in place. And the trough is made on the mandibular occlusal rib. And these mark when the patient has to swallow and hold, this wax is seated into the place. And after denture fabrication, we can verify the record made. In this article, they have compared about the 4 techniques like we can use a chin point guidance with the anterior J, or swallowing a free closure, bilateral manipulation, methods of returning the mandible to central relation position, and there can be the variations in the recordings obtained. Pantography, it is used clinically to measure the mandibular movement. It records a graphic record in 3 planes. It can be mechanical, which was given by McCollum and Stewart. It can be electronic. This is the pantographic tracing device. And disadvantage of this device is this technique sensitive, is very complex device, and also this we can see the graphic tracing obtained when the patient is performing the mandibular movements. This is the type of pantographic tracing. Now we have discussed the centric relation records and the various methods of recording the centric relation, physiological, functional, and the graphic methods, and the pantographic methods, and all the other methods which we have discussed. Now next is the eccentric relation records. It can be eccentric, can be protrusive, and lateral. Lateral can be right lateral or left lateral. See this, when the patient is instructed to move the jaw forward, move the lower jaw forward, and make the protrusive movement, then we can see some space between the posterior rims. That space is called Christensen's phenomenon. Why there is a space? Because when the mandible is moving forward, then there is some space between the posterior portion. We can see the space like this because it registers the influence of condylar path over the movements of the mandible. This protrusive movement is guided by the condylar path, and this helps us to determine the horizontal condylar guidance angle which the condyle makes along the slopes of the articular eminence as it moves downward, as it makes protrusive movement. This how we will obtain the protrusive intraocclusal record. In this, we will mark 6 mm beyond the centric relation position on the line which is scribed by the making the protrusive movements. We'll mark 2 holes, and we'll put a plastic plate onto these holes, and this pin should point into the holes, get inside the holes and get stuck inside, so that whenever we are making the records, the pin should not move. This is the protrusive record obtained. And this record will help us to determine the horizontal condylar guidance angle. And the lateral jaw relations, it influences the intercuspation of the teeth in the working, mastication, working movements. So lateral jaw relations, it influences the intercuspation of teeth. What are the lateral movements? Like when I'm moving the mandible to the right side, this is my right side, mandible to the right side. So this is the working side condyle, and this is the balancing side. Towards the side with which the mandible condyle moves is the balancing side, and the movement along which the condyle moves is the working side. So this lateral jaw relations, this lateral movements, it influences the intercuspation of teeth in the working mastication. That means during the functional movements, it influences the intercuspation of the teeth. So lateral angle is also very important, and it helps us to program the articulator. What are the lateral intraocclusal records? Side shift at set side shift guide at 45 degree, mark 6 mm from centric relation on left lateral tracing, and center the whole of the plastic piece over it. Right condylar wall is in protrusion. Side shift guide brought in contact with the wall. So in this lateral intraocclusal records can also be lateral condylar guidance angle can be obtained easily with the horizontal condylar guidance angle using this formula. L is equal to h plus 8 by 12. So we will make the protrusive records, and we will program the articulator, and after obtaining the horizontal condylar guidance, we can easily use this formula to obtain the lateral condylar guidance angle. This was the centric relation and the eccentric relation, which comes under horizontal jaw relation. So now if if we are supposed to do the jaw relation as a clinical step in the patient mouth, then what all steps we will follow. So first, as soon as the patient arrives, first we will prepare the rims, and as soon as the patient arrives, we will customize occlusal rims. First, we will check for the labral support and the buccal support. Then there should not be any negative buccal corridor. Then after checking for all that, adjusting the rims, customizing the rims, like for the improper lip support, if there is improper lip support, strained lips, then we will remove the wax from the labial surface. And if there is inadequate lip support, that the drooping lips, then we'll add some wax so that there is proper lip support, which supports the edentulous lips, which have lips which are drooping down. So support is very important in the edentulous patients. Next step will adjust the plane of orientation, occlusal plane. Occlusal plane should be parallel to the interpupillary line anteriorly, and posteriorly it should be parallel to the campus plane, that is the L of the nose to the tragus of the ear. So this way we'll adjust the occlusal rims and the plane of orientation. And then next step will be to determine the vertical jaw relation. We'll make some point to 2 points on the tip of the nose and the most prominent point of the chin, and then we will record the physiological rest position by using these facial measurements as a guide, and by asking the patient, like using phonetics as a method, like asking the patient to repeat the letter M, or the tactile sense as a method. We'll determine the physiological rest position, and that position help us to determine the vertical dimension of occlusion. So in this method, we have after that, with the help of the Facebook transfer, we will use the Facebook to record the orientation jaw relation, so that the relationship of the maxilla to the base of the skull is properly recorded as in the patient mouth, and recorded and transferred to the articulator similarly. With the help of the Facebook records, we have mounted the maxillary cast. Now we need to verify the centric relation. We are using the tracing assembly. So what we will do next step is the first we will center the cast, and we will this device used for this this device is used for the centering assembly, and then we will make this prepare the split cast. First, these notches are made, and the split cast must be made of different material during the boxing with the help of the boxing procedure. We'll prepare the split cast. We'll make some these indentations so that the these protuberances, so that the proper uniform thickness of the cast is obtained. Secondary cast is made, and we will use the material which is of different shade, like the dye stone we can use, because it helps us in easy visibility when we are mounting, and when we are programming the articulator. And also we are using the high strength stone, because the thickness of this secondary cast is just 3 to 4 mm, so we need strength in with this thickness, so we're using the high strength stone for making the split cast. We'll make some holes on the in this region, and also we will put some stapler pins on this region, on the split cast, so that it is locked with the properly with the mounting and does not move. This is the properly mounted maxillary cast in place, and mounted with the help of Facebook records, and also we have prepared the split cast. Next, we will record the tentative jaw relation, keeping the maxilla mandible rims, and guiding the mandible to centric relation position, and then checking these lines, if their lines are coinciding or not. And if they are, then we will lock the position with the help of stapler pins. The next, we will mount the cast on the articulator similarly as the record obtained. Not the record, as the centric relation record is made. Now we will reduce some wax from the upper portion of the mandibular rim. Why we are using this wax? Because we need some space for the central bearing assembly, and also the wax removed should be uniform, should be parallel to the upper rim, and also in some cases with the medially resolved ridges, they have sufficient intra space for the central bearing assembly. So in heavy ridges, this procedure will be difficult, because will not have insufficient intraspace. So central bearing point with the central bearing device is attached to the maxillary mandibular occlusal rim. This is the rims in place with the uniform separation. And then the tracers are attached. This is the central bearing plate, central bearing ball, and then tracers are attached. And then the patient is asked to perform the mandibular movement like centric is guided into centric relation position, and then the patient is asked to perform protrusive left lateral, right lateral movement. This first we ask the patient to sit upright and then guide the mandible to centric relation position. Ask the patient to perform the protrusive left lateral, right lateral movements. And these movements can prepare the arrow point tracing onto this plate. This arrow point tracing, in this, the arrow apex is the centric relation, and this center line from the center, from the apex is the protrusive relation, left lateral, right lateral. So marking this line from 6 mm from the centric relation to this line 6 mm, because it is a range of movement permissible from centric relation to the protrusive movement. And this line, some holes are marked with the help of pen, and we will put a plastic sheet onto this hole. This is the plastic which is kept on, it could be transparent, which is kept onto this plate, and then we will place the holes onto this the markings, arrow point tracings achieved. And similarly, we'll put the plastic glass piece in place, and we will plastic piece onto the place, and then we will, with the help of burr, we will make the markings wide enough, so that make the markings wide enough so the stylus or pin can go insert into the this hole. This is the arrow point tracing obtained. This is the centric relation record, and centric relation record, you can see there is perforation. Why there is perforation? Because when central in the centric relation, centric bearing point, this comes in contact with the plate. So this causes the perforation, but in protrusive record, there is no perforation. Why? Because protrusive record, when the patient protrudes the mandible forward, there is always a space in the posterior region that is called Christensen phenomenon. So that phenomenon does not cause the perforation onto the records obtained. That's to the cast. Now check records open. Now we need to, one next step is to program the articulator. First, we will verify the centric relation check records obtained. We'll put that record into the space, and then we will put the records onto the place, and then loosen the articulator, and then put the rim. This styler pin should be pointing onto the apex, should be fitted onto the apex made, and then we will verify the centric relation position. So this elastics are attached because it acts as a one unit, and the split cast acts as another unit. And the split cast, if the centric relation is verification is dependent upon the split cast, which should seat only into place. If this is not seating into place, then there is some wrong garbage with the centric relation recorded. Also, the check records, protrusive check records are also inserted into the place. And the protrusive check record, well, we are putting the protrusive record into the place, we will loosen the articulator, and then we can check for the horizontal condylar guidance angle with the help of protrusive records. And the lateral condylar guidance angle is obtained with the help of the lateral condylar guidance with the help of the formula. So this was the method of programming the articulator using the check records and obtaining the protrusive guidance angle and the lateral condylar guidance angle. This is the Hanau wide view articulator, which helps us to transfer the phase bore record taken onto the articulator and help in mounting the articulator in the same manner. And this was all about horizontal jaw relation.